Hello, my name is Nicholas Campbell. This is our poster, Shifting Paradigms, Transitioning from a Bolus to Drip Admission Process. This project was done with Eliea Sneij, Anastasia Brit, and Dr. Jensen Hyde. We're from University of Tennessee at Chattanooga Internal Medicine Program. So this project was intended to evaluate pre and post a quality improvement project targeted at improving the admission process at our hospital, Erlanger in Chattanooga. So the objectives here are to compare and contrast two systems of hospital admission process on the academic internal medicine floor teams, and to discuss how the DRIP system of admission may benefit the resident education experience. So to introduce what we're talking about here, hospital operations are often complex and require frequent adjustments over time to provide best and most efficient care for patients. Regarding an admission process, changes can lead to decreased time to admission, a quicker initiation of treatment, additional learning opportunities for residents, and increased patient volume. So regarding academic services, there are two different ways that we've seen admission processes. One are that we like to call the bolus system, and one that we call the drip system. The bolus system, if you have multiple teams, the teams take turns admitting patients on each day. So for instance, we had 3 teams at Erlanger, and every third day your team would be solely in charge of admitting patients that day. Alternatively, there is a drip system where the teams will take turns admitting patients every single day. Theoretically, and through our observations, we noticed that through the bolus system, when you admit every third day, your team is more likely to have highs and lows in patient census. And overall, it was suspected that the patient census on the academic services was lower than what it would have been on the drip service. So we hypothesized that changing the academic process from the bolus system to a drip system through utilization of a patient-coordinated distribute patients would cause an increase in patients seen on the academic service. So how do we decide to evaluate this? This was a single-center post-intervention quasi-experimental study design to evaluate the change in patient volume post-implementation of a streamlined drip system at an academic medical center. We had 2 arms, a pre-intervention arm and a post-intervention arm, where the pre-intervention arm was through the bolus system and the post-intervention arm was through the drip system. To add consistency, these were done during the same months of the year, and the post-intervention was done a couple months after implementing the new change to allow for adjusting to the new change. Our primary hypothesis was at least a 5% increase in patients through the new admission process, with a significance level of 0.05, power of 80%, and a 2-tallied test. A minimum 395 patients, 790 total, was calculated to be required for each of the pre and post processes to reach the testing power. So our results was, during the bolus system, a pre-intervention period of 6 months, a total of 808 patients were admitted between the 3 academic medical ward teams. This was, on average, 37 patients per week. In the post-intervention, this number rose to 877, an increase of 8.5% total. And the post-intervention of the academic service was seeing an average of 40 patients per week. So the p-value was just a little bit underpowered, but there was a clear trend of increased patient volume. There's a couple other factors that definitely confound our results. In 2019, we always had one of the 3 ward teams had an extra intern and an increased ACGME cap of from 14 to 20 patients. Since the numbers trended positively despite being able to theoretically have more patients on service in 2019, we did not adjust for this and determined that it only further solidified our point of that the drip system on average does trend to have more patients. So overall, this study highlights how system modification could lead to visible change, and these things, having more patients admitted, we suspect translates to improved patient care because these patients were getting admitted regardless, but now they were admitted probably more evenly between the hospitalists and the academic service. It also lends to additional learning opportunities for the internal medicine residents, in the motto that if you see more, you likely learn more. So here are some graphs to demonstrate the changes that we saw. In the top left corner, this is a comparison of total encounters. Encounters were determined by patients seen on a specific day. So, for instance, if a team saw 14 patients, then that day there would be 14 encounters, and these were tallied up every day throughout the time period. There was looks like 6,200 in the post-intervention arm versus 5,600 in the pre. In the top right corner, this is the data that was mentioned in the results of the nearly 880 patients in the 2020 post-intervention arm. In the bottom left, this is the encounters per day. You can see, and per week compared, you can see there's about a 10%, 11% of encounters, an average increase there, which correlates well with the total number of encounters in the top left. And then in the bottom right is the comparison of number of patients per week and per day. And then the per week was the 8.1% increase that just was underpowered. But everything has been trending towards, even despite having less residents and less of a patient cap, the drip system did lead to more patient encounters. So, in conclusion, small changes to the admission process can lead to big changes overall. There's other nuances to the difference between these, that just consistency is likely allows for higher resident satisfaction, and theoretically that could be something else that could be investigated, or another aspect that could be reviewed is adjusting for the 2 intern team versus having just the 1 intern teams in 2020. I appreciate you listening to our talk, and thank you.